begin. So I welcome everyone to this webinar and panel discussion of the program in global palliative care within the Department of Global Health and Social Medicine at Harvard Medical School. And thanks for joining us on such short notice. Our topic today is palliative care in conflict situations. Should it be applicable only for serious illness-related suffering? I'm Eric Krakauer. I'm director of the program in global palliative care here in the Department of Global Health and Social Medicine at Harvard Medical School, where I'm also associate professor of medicine. And I'm an attending physician in a division of palliative care and geriatric medicine at Massachusetts General Hospital and honorary chair of the Department of Palliative Care at the University of Medicine and Pharmacy in Ho Chi Minh City, Vietnam. Conflict situations are very prevalent, unfortunately, around the world, and they generate unspeakable suffering. I could mention Sudan, Palestine, Ukraine, Libya, Democratic Republic of Congo, Yemen, Syria, Myanmar, the list goes on. The suffering is unspeakable, both because words and, for that matter, images fail to convey the magnitude and severity of the suffering, and because the voices of the suffering tend to remain unheard or unheeded. Palliative care is most fundamentally a response to suffering. While the full definition of palliative care remains a topic of debate, there has been wide agreement since the publication of the report of the Lancet Commission on Palliative Care and Pain Relief that the suffering to which palliative care responds is, quote, serious health-related suffering. In other words, suffering associated with serious illness. With this panel discussion, we want to pose the question of the role of palliative care in conflict situations. Is it important or necessary for palliative care to focus exclusively on those enmeshed in conflict situations who have a serious illness? Is it medically and morally acceptable for those with palliative care training not to attend to those suffering psychologically, socially, or spiritually due to political, ethnic, or sexual violence or forced displacement, even if they do not have a serious physical illness? Or should palliative care, again defined as the discipline of preventing and relieving physical, psychological, social, and spiritual suffering, should palliative care be considered an essential part of every response to humanitarian crises? To address these questions, we have a very distinguished and remarkable panel, all of whom at some point in their lives were forced to leave their homes due to political or ethnic violence. Dr. Nakhla Ghaffar is a clinical oncologist and palliative care specialist from Sudan, now working as a medical officer for the World Health Organization's Eastern Mediterranean Regional Office in Cairo. In 2010, Dr. Ghaffar founded the first palliative care service in Sudan at Khartoum Oncology Hospital, and she remains its director despite having to seek refuge from the war in Sudan. She has been recognized by the American Academy of Hospice and Palliative Medicine as a world visionary, and she serves on the board of directors of the International Association for Hospice and Palliative Care. Dr. Ghaffar.
Thank you so much, Prof. Eric, and thanks to Harvard University for this opportunity. As Professor Eric mentioned, I am a clinician. I've been working with cancer patients, and recently I have been displaced because of war. In Khartoum and in Sudan, a lot of times there were wars, but they were very far away from the capital. They were in the far west or in the far south. We never thought that we would be facing a war situation. And it happened suddenly. It was on a Saturday. And luckily we were at home because everybody who was on the streets on that day, they died, they were killed, or they had to seek a nearby place to stay in for 2 weeks. So if you were in the market, you have to stay there for 2 weeks, and some people were very difficult for them to get out. There was a painter, they said, the painter was trapped in the museum and he had to eat his paints because there was nothing for him to feed on. We were at home and we heard the bombing, and by telephone we understood that there was a conflict between two armed forces, the main army and the effect of it, which is the rapid support forces. And we understood that we were not the main targets, but it was very dangerous for anybody to go outside in the streets. So we were trapped at home, calling people we know. And that was good because the telephone and internet was functioning for the first few days. And we were finishing the food that we had at home. Then electricity went off, water was cut. On the first day, we couldn't survive any more at home, and we said it's better to get out. Also, I watched some videos and which showed me what is the situation that happens in a city when it is under war, what happens in the first 30 days. So it was a plan that we had to go out. We made use of a truce because there was 4-hour truce periods. So everyone in the house quickly put a backpack on their back and we ventured into the streets. Like you walk in front and you look in behind you to see what is happening and ready to run. And to reach another part of the city, which usually takes 20 minutes by car, we spent almost 3 hours to arrive there, taking like 4 different vehicles and walking some part of the way. And we reached a safer house, but we found that they also have no electricity and that the conflict is coming near to them. So we had to move again and again. And my story is so much better than a lot of other people who didn't think about moving in time, and they were trapped inside the city. These people for months, sometimes 2 months, 3 months, cannot venture into the streets, and we're hearing the bombing day and night. Like you cannot sleep for the bombing. Even for me, who attended like 4 days or 5 days intensive bombing, after a month and 2 months, one time I was in Cairo and there was a plane like moving up, and then I was startled because of the memory of the bombing. But more people stayed for longer period, and they were faced with horrible experiences. Some of them are my friends and colleagues. And when they had to move out at that time, there were corpses all over the place, dead bodies. There were rabid dogs because the dogs were feeding on the dead bodies. Before them moving from their homes at night, they hear the screams of young girls being raped. People were disappearing all the time. People were lost. I have my friend who's outside, she's working in the Gulf, and her father, they couldn't reach her father at all, and they don't know his whereabouts. A lot of people are lost, disappearing. Families are broken, families, communities. Nobody goes back to their normal life. Like I haven't seen my aunts for a long period, and I don't know whether I will be seeing my aunts who are still in Sudan. The community and your life. So when I was moving from Khartoum, which is the capital, to the north of the country. There, I am almost, you can say I'm nobody. Nobody knows about me. There's no support. Even I discovered that the cities outside outside, or the houses outside the capital are totally different from the situation that we were living in Khartoum. The capital was affluent. There was water, there was siphon. So when we went there, in other cities, it was a struggle to use the pumps. Maybe you have seen it, the pump, the London pump that was famous. What's his name? Jon Snow. So that one I have seen. I have seen with my eyes in the north of the country, and I have used it. So that was the means of getting water. And we realized the people who were in the other parts of the country were having a lot of reduced infrastructure and easier and simpler life. And we struggled to live there. We struggled because also we don't have any means. You don't have money. You don't have, the banks were not working. The internet banking is not working. And as I mentioned, there were a lot of losses of lives, but at the same time, there wasn't the normal procedures of mourning your lost person. Like sometimes somebody dies in a place and then the people call to the neighbors, okay, please bury that person. And they bury him inside the house because they cannot go to the burial places. And this loss of connection to your normal life, and for patients, it's even worse. Patients, they cannot continue their management. There is no pain medications. I have a lot of patients contacting me and sending me photos and tumors increasing in size, curable situations turning to be incurable. It's very disastrous. One thing I'd like to mention is that even for Sudan, it's horrible. And till now, every day there is a city falling. Today we have Medani falling, and people were just running in the streets for their lives, going to the nearest city near to them to survive. But still, this situation is so much better than other places. And here I'd like to remind ourselves of the situation in Gaza, because they are a little bit more trapped. They don't have a place to run to. And this is my, I think I'll stop here. Thank you.
Thank you, Dr. Nakhla. Thank you for sharing all those very difficult, painful experiences. Would you have, before we move on, sorry, the light just went off here. Would you have any comment about the role of palliative care in such humanitarian crisis situations? You're both an oncologist and a palliative care specialist. Any thoughts about that?
Yes, I think you can see my screen. I gave this in another presentation, and I was thinking about how the situation of patient changes when there is a conflict situation. So there is affection. People are affected physically, psychologically, spiritually, and socially. And then I realized, really, it doesn't need to be a patient, you know? So just think about somebody who's fit, has no problem, and there is a conflict situation. There is the affection in his physique, in the way of you are running, you are going someplace, searching for security, avoiding to get killed. looking for a place to lodge, looking for food, if you need medication, looking for medication. Of course, there is need for medication, especially in those situations. There is increased physical injury. I remember I took with me some bandages and put them in the bag. And with all this physical situation, your immunity goes down. During my travel, which was like 2 months from Khartoum till I reached Cairo, I had pneumonia 3 times. And loss of sleep due to bombing. All these are physical. And psychological, you are affected about the situation. You don't know what is happening. You are afraid about the future. You feel displacement. You lose your property. You lose your lives. And as I mentioned, spiritually, those whom you lose, you cannot mourn them in the proper way. You feel some guilt for taking the wrong decisions or not helping others. And socially, as I mentioned, there's disruption of the communities of your family, your acquaintances, your friends, and this, financial difficulties. So I agree with you, Professor Eric, that it doesn't need to be a sick person or somebody with a chronic condition, but conflict by itself puts us in this situation where we really need palliative care.
Thank you so much, Dr. Nahla. Thank you. That's very, very powerful. It's hard to move on from that, but thank you for sharing. And I should mention that this webinar is being recorded and will be available at the website of the Department of Global Health and Social Medicine at Harvard Medical School. I'd like to now introduce my friend and colleague, Dr. Tamam Aloudat, trained initially as a surgeon and a career humanitarian response expert from Syria. He's now president of the board of Médecins Sans Frontières, or Doctors Without Borders, Netherlands. He previously worked for many years with MSF, Médecins Sans Frontières, Switzerland, where he held several leadership positions. And he was also in the past managing director of the Global Health Center at the Graduate Institute of International and Development Studies in Geneva, Switzerland. He also serves as section editor of humanitarian health at PLOS Global Health, one of the top global public health journals. In 2017, he published one of the first calls for integration of palliative care into humanitarian crisis response. So thanks so much. I know you must be incredibly busy right now, Dr. Tamam. Thank you so much for joining us and agreeing to speak with us.
Thank you very, very much for having me. It's a privilege, as always, to work with you, Eric. And thank you for bringing this particularly important point at this stage. It took me a minute to figure out what are we talking about when I saw your brief email, and it took me a minute because the questions you're asking were I think partially resolved in my mind, but the reason they aren't resolved in general came to me after a bit of contemplation. Let me just start from the humanitarian part rather than palliative care part. In humanitarianism, we have a sort of a set of mythologies that constitute our identity and the way we work and so on. And I want to mention a couple of them. One of them is caring for the sick and dying. And most of modern, modern Western secular humanitarianism started with Henri Dunant, who is the founder of the Red Cross. And his story goes that, he arrived at a battlefield in Solferino after the battle was ended, and then he, sort of brought up the villagers to care for the soldiers that were left behind, a lot of whom died, and the battle is said to have 40,000 people killed in it. And he cared for the sick. Obviously, neither do you know the villagers were medical practitioners, but somehow the act of caring counted for something, and counted for the creation as well of the next 170 years of humanitarianism. Another example many will know, particularly is Florence Nightingale in the Crimean War, who also had the sort of angelic mythology of the figure who cared for the sick, and that is with more than a century old, mind you, it was a revelation for me that we didn't have antibiotics until the late 40s. So that was before pain management, before antibiotics, before pretty much modern medicine was created. So just to put it, at least what we tell ourselves is that the act of care with whatever technology available to us is what matters. Now, we do extensively technical medicine now in many places that would have been unimaginable even 15 years ago. We provide surgeries, we have neonatal care clinics in some of the poorest and most troubled places. We do CPAP, we have NICUs, we do stuff that aren't necessarily something I would have imagined. I graduated from Damascus Medical School. We didn't have CPAP in it when I graduated, let's put it that way, in the biggest hospital in Syria. So the world has changed in terms of providing technical medicine quite intensely. And from conversations we've had before, and from the guidance you very generously provided me over the past few years on how to think about palliative care, Eric, the reason I thought about palliative care the first time, as you mentioned, is in 2016. I was debriefing a colleague coming back from South Sudan, and she was telling me about a case of a woman who came with a very advanced breast cancer which was untreatable. And just to put it in context, South Sudan nearly doesn't have surgeons. There's no, even a simple surgery is hardly possible, let alone at the border with Sudan, where there are no roads to go to Juba and so on. And I asked, so what did you do with her? And she said, well, we sent her back home to die in dignity. And that was literally the sentence that broke my mind at the time, is, and that came after a family friend died in London of cancer, who was described to me. She had the morphine clicker in her hand, and her facial expressions in pain were unbelievable until she clicked another dose of morphine. Those were the final hours of her life. And the two just couldn't work together. Where is dignity in pain, in dying in pain? So we started working on it. Many years later, and many devoted colleagues later, we have quite an extensive palliative care work, from the availability of pain management quite well in almost every project MSF does. But then it comes to a lot of psychosocial support, end-of-life care, and so on, particularly in projects where we have, for example, HIV terminal patients or tuberculosis terminal patients or so on. So all that is an advance, but we are still accepting, transposing palliative care as is prescribed in Western societies into places that do not correspond in the medical technology or possibilities. So what does that mean? What are you palliating? What are we trying to palliate? Now, there's obviously people with serious illness who would have died in agony otherwise, but then let's talk about other things. I've worked in Niger, in the south of Niger. We had a intensive care unit in a children's hospital with 40 beds, full doubly. And that's the intensive care unit in a 700-bed hospital. The day we didn't lose 10 to 15 children was a good day. I spent weeks there, and there was only one single day where there was no mortality during the night. Those children didn't have a serious illness per se. Most of them had severe malnutrition compounded by severe malaria. This still qualifies for palliative care in every measure possible. We're talking here about Yeah, that the same goes for Ebola. We had Ebola patients die on us in large numbers in West Africa during the Ebola outbreak. And one of the issues wasn't only pain management. We had pain management. It was the fact that people were admitted, put in a bed in a big tent with the EP, the personal protective equipment that obscured entirely the care. People died being cared for by people they cannot identify or see smile even. This is part of palliative care that was missing and couldn't have been done better, to be honest, at that point. But I have seen in COVID an image from Italy that I like of a person in PPE aiding an old woman, and they had drawn a smiley face on their gown. That in itself is just a consideration further. I don't pretend that this will have solved any particularly, clinical problem. But that's where I'm going to, is palliative care is not exclusively a clinical activity. Now, talk about injuries and conflict. I've worked in northern Jordan with Syrian injured people, where we did not restorative, sort of harm reduction surgeries, because people weren't bleeding exactly. They came across the border, but we had multi-drug resistant, multi-antibiotic resistant injuries. We had people in agonizing pain with amputations that were done in tents or on the street. The same goes for Gaza now. We did that in South Sudan in Benchu. But in Gaza today, I want to talk about that for a second. Ghassan Abu Sita, who's a surgeon from the UK, has talked publicly about having to amputate multiple limbs of children under non-surgical conditions in Gaza. There are multiple injuries that are beyond what a Western hospital would be able to manage today with any competence. Let me put it, your medical school would struggle with managing almost any of those extensive injuries, partially because there's no standard to those injuries. And I've worked with the explosive device injuries before. There's no standard that would have been algorithmic to a surgeon to do what to do. It's experience and sense that brings them. And even in the humanitarian world, we barely have a handful of surgeons who are truly capable of handling something like this from A to Z. The other thing is, there was time in Gaza, and this is not exceptional to Gaza, but it's extensively present now, where we didn't have pain management for people under the knife, under surgery. There wasn't anesthesia, both because fuel was out, there were no medicines that to be renewable. There were amputations done on daily basis without anesthesia. Makes you feel like you're in the 1890s again? Yes, that's exactly how it was made. The other thing is, it's not only that, it comes in, and this is the biomedical part. Let me move it a step towards the rest of it, what you list as the social, the cultural, in Ebola, we struggled because we couldn't give people a respectful burial. And people stopped sending patients to be tested. In Gaza, people are dying in pieces, and there is the amount of anxiety, the amount of fear, the amount of trauma, and that has happened in Sudan as well. We work in Darfur, and we've worked around Khartoum, and the exact same thing happens. What I'm arguing here is that we do have a bit of a sanitized image of war coming from, chivalrous and World War II movies and stuff like that. War has never been sanitized, and it's much worse now when there are large civilian populations that are the primary target of hostilities. We don't have post-surgical care. We don't have much of what is considered an absolute minimum standard. Why do I say all that? Is because I don't think we can avoid doing what palliative care claims to do, which is caring for the pain and suffering of people who are either at the end of life or untreatable. And I'm reaching a point where I'm saying there are many cases that are perfectly treatable in your medical hospital, in your university hospital, that are absolutely not treatable anywhere else. And if you take the logic of palliative care, of dealing with issues that are untreatable in normal situations, then you transpose not the procedures of palliative care the algorithms of applying it to oncological patients or senior patients or end of life. You transform the spirit of taking care of people, reducing pain, increasing care, providing safety and comfort, and you put it on what is actually untreatable under the circumstances. In Ebola, it was Ebola patients who were positive and had no treatment. In Gaza today, in Sudan today, in many other places, in Congo, in Central African Republic, and Yemen, Libya, and you count, and the count is long, it is a whole wide array of issues. And if palliative care is to own its intention and apply properly in a humanitarian setting, it needs to rid itself from the algorithms and take on the what do we need to do for us to be honest to the message of palliative care that has come many more steps from just caring for hospices, for older patients in hospices or cancer patients, and to be actually active. And that cannot wait until the cessation of hostilities. That cannot really, be, okay, we'll do that once we have that. It is an intrinsic part, more so than anywhere else, is under active conditions of conflict. The last thing I will say is this falls, in my opinion, in a bigger trajectory or discourse, which is we really need to start in humanitarian setting, in low resource setting, in poverty setting, start to move ourselves from thinking about medicine generally as a vocational technical capacity to provide an algorithm to patients, and back into what in my part of the world used to be called, a doctor used to be called Hakim, and Hakim means a wise person. And wisdom counts more under those circumstances than biotechnical capacity to diagnose and treat, especially when you find yourself deprived of all the tools that you would know around you and provided only with basics and patients with absolutely extensive need. I'll stop here and thank you very much for having me today.
Oh, thank you, Dr. Tamam Aloudat. That was so thoughtful, and you made me think of so many things. One thing that comes to mind is that you mentioned the old name for doctor in Arabic. In Vietnamese, the old name for hospital, and forgive me to my Vietnamese colleagues for my bad pronunciation, the old name for hospital was Nhà Thương. Literally, it means house of love. And the new name for hospital is Bệnh viện, which means sick institute. Now, would you rather get care at a sick institute or a house of love?
Exactly. And in that sense, I just want to mention there is a value, despite the pretentiousness of quoting French philosophers, there is a value of going back to what Foucault talks about about the illness and disease and the hospital as an institute of social control, in addition to it being an institute of care and healing. And that has been prevalent in medical sociology for good and for bad. And we shouldn't allow that to trickle down. Instead of the technology and capacity trickling down to humanitarian settings, we let the social control aspect of medicine trickle down. So that's a conscientious place where we can start and end. And it's not very difficult because, anyway, humanitarians are a ragtag bunch who enjoy breaking the rules. So do it for a good reason, at least.
Thank you, Dr. Tamam. I think we have lots more to talk about. I see we have lots of common interests, but your experience is so important and your voice is so important. So thank you for sharing. And again, it's very hard to, after these two very powerful talks from Dr. Nala Ghaffar and Dr. Tamam Aloudat. Christian, I'm sorry to put you at the end. You have to, after Mozart and Beethoven, you're like Brahms, you have to follow the unfollowable. But I'd like to introduce my old friend, Dr. Christian Tizimira, who is a Rwandan, also trained as a surgeon and palliative care physician and healthcare theorist. Dr. Tizimira, Dr. Christian, was born outside his homeland and returned with his family after the 1994 genocide against the Tutsis. He was appointed by the Minister of Health as director of a major hospital in Kigali at the age of 29. And in a few years, he significantly improved patient outcomes, for example, dramatically reducing maternal mortality, and also dramatically improved staff satisfaction. He also founded Rwanda's first hospital-based adult and pediatric palliative care services at that hospital, Kibagabaga Hospital. More recently, he co-founded the Rwanda Palliative Care and Hospice Organization, and he is the founder and director of the African Center for Research on the End of Life, or ACRIOL, which studies adaptation of palliative care to African cultural, social, and medical contexts. So welcome, Christian. Thank you for joining us. Please, you have the floor.
Thank you, Eric. Thank you for the invitation, and thank you for the Harvard community for this opportunity to share about my experiences. It's, as you said, it's difficult to talk about after Dr. Taman and Nala mentioned about, and we have common experiences on what they're sharing about conflict situation. From your question, yes, my answer is totally yes. It's 100% yes. I'm going just to share about a few slides to understand why I'm thinking palliative care will be the paradigm shift in conflict and also in post-conflict situation. So I live in Rwanda. Rwanda is among the smallest country in Africa, but not a small nation with 13 million people. And as you may see, 15% of our population is under 20. It's a very young country, and it's due to the genocide against the Tutsi in 1994. But it's also the most, one of the most dense country with almost 500 people by kilometer square, and agriculture is the most resources in the country. So this is now 30 years after the genocide against the Tutsi up in 1994. And in 1994, 1 million people died in 100 days. And it's not only 1 million people died in 100 days, but humanity itself seems lost that time. And I strongly believe that the concept of palliative care, among all the contributions have been done by the government in this country to rebuild the country, but the concept of palliative care will contribute a lot to bring back the sense of humanity we lost during the genocide. Why? Because palliative care is not only about withdrawing or withholding medication. Palliative care is also about humanity, dignity, and Ubuntu. So after the genocide against the Tutsi in 1994, and from being witnesses the post-genocide unnecessary suffering in the country, so I dreamed to be a surgeon, because I think to be a surgeon would be the best way to rebuild the country and reintroduce the sense of humanity lost during the genocide. But until I met a very young guy, 24 years old, who was really dying in pain. I was familiar with pain, but his pain was totally different. It was pain and suffering on the same time. And the worst sad part of this story, his mom came to me and kneeled before me and asked if I can do something for his son. This second pain was worse than the first pain, because emotional pain is worse than physical pain. So as a physician, I felt that I failed twice. I failed as a physician because even if morphine was available in the hospital in a small quantity, but I couldn't prescribe morphine because I feared to prescribe morphine. But also I failed as a Rwandan, because in our culture, when an elder person kneeled before a young person, culturally, you failed. So I went back home and questioned myself, what the reason spending so many years in medical school, and if I couldn't relieve pain for those who are dying? What the reason to wear a white blood coat and the stethoscope, walking in the corridor of the hospital, if my role is just witnesses people who are dying and suffer, what's the reason to spend so many years in medical school if we can't relieve the simple suffering from the patient and their families? What's the reason to be a physician? So I moved from my dream to be a surgeon and become a palliative care passionate. So I came just to realize if we need to rebuild back the sense of humanity we lost, so we need to focus on the patient, on the person, not necessarily on disease. Because treating the disease and treating the person are two different concepts. You can treat the disease without treating the person. But if you treat the person, you must treat the disease as well. And then I just come to realize in Rwanda social context that we have a saying, when you are well, you belong to yourself. When you are sick, you belong to your family. It's not about an individual, it's about the community. If one person suffers, it's the whole community suffer. And that is something really important. It's a patient autonomy, but we have the community responsibility at the same time. And that brings a new and different dimension of palliative care. It's not only about physical aspect, but it is about the person. But if you focus on the person, we're talking about the community as well. So we need also to understand how we come for the context. We've been trapped by different cultures, Euro-American clinical and culture experiences in Africa. And mostly our approach is not patient-centered care, it's community-centered care. And this is how the role of palliative care play a major differences in the paradigm, because it's not about the patient, it's about the person. The person is part of the community as the community is part of the patient, the person. And also the meaning. And part of my ethnography research, I understood that traditional palliative care, end-of-life care existed before modern palliative care exists. They didn't call it palliative care, but it was exists. More practiceful, not focus on the physical, but focus on the person, the family, even the environment of the patient. As Eric mentioned, how do you think about the new palliative care? Is it something new, or are we going to go back and understand the root of palliative care? So where is it started and how is to be gone? And if today we need to build a global community in palliative care, we need first to connect communities, because we cannot connect communities without connecting identities. And Eric mentioned, and my colleague mentioned very well, don't be trapped on international standard. If are not really focused on the critical and the dignity and family and the patients, because it could become a social injustice and not a thinking care. This is the major key critical of the dignity and the humanity of the patients. So, and Ubuntu, and this is why I'm trying to realize, Ubuntu is one of the strong rooted philosophy in Africa. And Ubuntu is the meaning, on my understanding, is one of the best way palliative care could be expressed, because Ubuntu value life, dignity, compassion, humanity, harmony, and the reconciliation. We don't talking about the disease, we're talking about the person. And on my research, I think Ubuntu will be a good response to the suffering, because it's for the dignity of the patient, the community, and the society. It will be also a social justice, because we focus on the patient. A very good system of social protection, because we re-engage the community. When there is a disease, when there is a conflict, when there is a trauma, there is a fracture between the person and the community, the person and the environment. And in terms of homegrown solution and contextualization. And my colleague mentioned about that. We need a decolonizing process, because the health system, including the health facilities, it's a post-colonial representative. Don't be surprised to see our patients go to see traditional healers first, because that is representing their identities. We need to remember something. From my experiences, the way people die can reflect how the society lives. Thank you.
Thank you. Thank you, Christian. You know, I think that there's been, from at least Dr. Tamam and Dr. Christian have both spoken about previous ways of thinking about care. And I want to propose that that there's a risk. There's certainly a risk of just thinking of medicine as technological, as algorithmic, as you say, Dr. Tamam. But I think there's also a risk of nostalgia, a risk of assuming that that things in the past were better and we need to get back to a better past practice. So my question for all of you, actually, for the panel, is about how to, in general, how to integrate salubrious or health promoting traditions with the important aspects of technological medicine that can prevent and relieve suffering. And specifically, I'd like to ask about how palliative care can be integrated into humanitarian response. So the term, is the term palliative care itself a problem? Does it need to be called something else? People-centered care, some kind of care that's culturally and individually adapted, that's not just an algorithm and not something that's invented in Boston and London and Houston. Does the name palliative care need to be revised? But again, how to integrate palliative care into humanitarian response, not just for those with end-stage cancer or end-stage major organ failure, but is there a way to do that for people who are severely traumatized, who are likely to develop post-traumatic stress disorder, who have anxiety disorders, depression, prolonged grief disorder, who are malnourished and have no home and no source of income, and who are asking, why did this happen to them, and who are having crisis of faith. Dr. Tamam, your hand is raised, please.
Thank you very much, Dr. Eric. But let me start by there's a very valid point to not being nostalgic to the past. But when we talk about medical technologies and capacities, and here is not only palliative care, but generally, when we try to apply the best practice to a humanitarian setting, my observation is we take the best hospital we know, say Mount Sinai, and then start cleaving at what's unfeasible or unaffordable of it, and then put it somewhere else. You keep taking chunks out of what is considered the state of the art until you reach something that you can technically implement and can afford. What happens is what gets cut out is what's considered the fat in medicine. And the sad part is that fat is the care, is the affection, is the relationships, is the caring for patients, is their families, is all those things. In MSF, we have just passed the motion, which is our governance way of the association, saying we think something should happen, which is we want every child caring ward or facility in MSF across the world to have child-friendly paintings on the walls. It doesn't really take much, but once you convince yourself that you are, doing the bare bones stuff, you stop doing those other parts. The alternative is probably an emergence of a healthcare system that starts from the circumstance rather than from the gold standard. That doesn't mean that you need to neglect any of the technical state-of-the-art things. When you choose to do something, you should do it well, otherwise it's negligence. But it starts from the agency of patients and community rather than from the desire of the treating physicians. It starts from what people want to see and want to have. And then it comes to palliative care. There are things that I think shouldn't be overlooked. One of them is pain management. One of the problems I've surveyed and we have seen in MSF across the board is fear of using opiates in managing pain. And that corresponds not with a reality in places we work, but in realities in our minds, which is the opiate epidemic in the US, which creates a bad name for the use of opium as a pain management. From countries that refuse the transportation of opiate-based painkillers, even inside a big emergency. And let's face it, if you are coming in a conflict or after an earthquake, to not have an effective oral pain management is negligent. So this is a bunch of stuff that are very easy. They are not technical. They are policy-based issues that need to be addressed. Now, the rest of it is slightly more complicated, but I think palliative care can have a vanguard role in this, because palliative care is, in essence, caring for hopeless cases. And I say that affectionately. In humanitarian mind, we save lives. So lives that can't be saved get neglected. And if we shift from that point of view into any time of a patient's life is valuable as it is, whether they can be healed, saved, treated, or not, then you don't need to change the name, because we're talking about care here. We're talking about an ethics of care rather than an ethics of, a sort of consequential utilitarian one. We do triage because some people need faster, but that doesn't mean that we neglect everybody else. And I think in that very sense, palliative care is the epitome of doing something good, regardless to the utility of it. And there's always something that can be done to make patients' lives better. That is not costly, not highly technical. When we do something technical, it should be done properly and technically well. But when we are there, we need to consider not only the consequentialist idea of, we need to save lives, until that becomes a harmful mantra in itself. We need to think about how can we care. And I dare say this is a skill that is much more prevalent in nurses than in physicians. And I think that part of that transformation is more leadership, which is not as simple as it appears. There's a lot of resistance. More leadership from the allied medical professions led by nurses and so on in humanitarian sector. Thank you.
Thank you, Tamam. So follow-up question, and again, it's for all of you. I can remember making rounds with Dr. Christian here in Boston, and he heard me having conversations about planning for the end of life. And I remember, Christian, you said to me, I can't have those conversations in Rwanda because every such conversation reminds people of the genocide and reminds people of the horror. I don't know if I'm repeating what you said correctly, but my question for all of you is, in the crisis situations that you mentioned, where you've worked and that you've experienced yourselves in Sudan and DRC and Yemen and Gaza, the suffering, the psychosocial suffering is so severe. Can we? Is it going to be feasible? Is it going to be possible to include psychosocial supporters, social workers, psychologists, spiritual supporters into humanitarian response teams? Or is the algorithmic approach to dealing with trauma save lives and not worry too much about suffering because we're so focused on saving lives? Is that itself a defense against confronting and recognizing the magnitude of the suffering, because that can be so overwhelming? So I guess the questions are, one, how can there be a staff members of humanitarian response team? Should it be required that there be training and attention to palliative care? And then how wouldn't that be very, very difficult emotionally to deal with such enormous suffering as one's role in a humanitarian crisis. Dr. Nahla, please.
Yes, I think when the situation is like in conflict and there is scarcity of personnel, I think, and as my colleague Christian mentioned, that the role of the community is very important. So we need to shift roles, and we need what do you call it? Networking, because at least somebody feels somebody is caring about them. In Sudan, here there is a nurse. A nurse is playing the role of a doctor, and two volunteers are playing the role of a nurse, and they are using a classroom to provide care for a patient or if somebody who's wounded. So I think this shifting of roles is very important. And our roles as palliative care physicians and palliative care leaders is to train more and more people to have this backup and to have this system of support, because as you mentioned, we need to train the psychologists, train the social workers, and even train lay people, because you never know when you shall need them. And I remember on 9/11, when there was a lot of deaths from UK, I think it was some professors moving with a full team of psychologists to New York, and they were counseling the family members who also traveled, and supporting the families who have lost a lot of people. Thank you.
Thank you, Dr. Nahla.
Thank you. If I may add something, as my colleague mentioned, Eric, yes, my time in Boston was really interesting, and I've learned a lot from your experiences and from American perspective. But when I went back home, it was really difficult to replicate the same model, because I couldn't understand some of the terminology and the people was using there, because in our setting, the context was totally different, because we lean on the community to cover when you are in a conflict, when you are vulnerable, it's sense of naked. You are naked in the community. So it's why the community has to be re-engaged to cover that nudity, and that is something really important I've learned. And in our context, I totally agree with someone say we don't need to change the terminology, because I don't think if you move $10 on left pocket and put it on right pocket, that will make it $50. It will be the same. So it's not about changing the terminology, it's about how the content. And we don't even use palliative care in Kinyarwanda, because that term doesn't exist. Even end-of-life care. End-of-life care, it's a very academic word. But in my context, when I want to explain, it's not about end-of-life care, it's about life until the end. Because in how to change that paradigm is what we are doing now by introducing, it's not about the nostalgia of the past, it's about how we can learn from the past to building about the future. The same experience happened during the genocide. What was the lesson learned from the genocide? How people can heal. When the genocide happened, I was 15. I didn't know why people were killing each others. I didn't know about those to reflect about the difficulty and the unnecessary suffering just because people are human beings. And I had to reflect that back becoming a physician, and my perspective changed completely. It's not about how I can treat the disease, it's about how I can treat the person. So what will be the philosophy driving our care? What about when we mention about care? And that's why, if you remember well, when we were in MGH during our road round, I remember when we go and see a patient, we went there, the room was so big, and I was joking to you and say, oh, Eric, this room is so big, I can live with my whole family here, because the room is so fancy, you know, with TV and everything. But I was really surprised to see the patient alone, but surrounding with so many pictures. And I was asking, and I asked you, Eric, where are those people? Where are those people? And it seemed like the patient was so happy in the pictures, surrounded by family, friends, making funny. And I was like, Now is not end of life, but where are those people? And that's reflect my own practices when now we lean on the community, because it's not about specific person, because it's about the community, how we can engage the community. It's why community healthcare playing the same role to rebuild and relieve the suffering. And palliative care is more than just one or two specific components in holistic care. Thank you.
Thank you, Christian. I see that it's now 2 p.m. My big question in my mind now is how to operationalize what we've been talking about. Is it possible how to integrate palliative care, psychosocial, spiritual support into so that it becomes a standard part of humanitarian response, and also, as was proposed, for example, at MSF. Is it possible to have as a standard procedure to, if possible, to work with the community to try to build capacity for psychosocial support in the setting of, in the chaos of humanitarian crisis? If maybe Dr. Tamam, would you like to have the last word?
Thank you. I do believe that we are in a very good place in as opposed to 10 years ago, let's say, in accepting that palliative care is needed and practicable in humanitarian settings. We have guidelines from WHO, which Dr. Eric, you've co-authored and was one of the lead authors on. My issue here is, rather than standardize and operationalize, I think we need to demonstrate. Palliative care is deeply cultural. What people care about is deeply cultural. It's deeply contextualized. It's hard to apply, the issue is not to avail instructions as much as to exchange information about how people found ways to provide palliative care in all its dimension in different humanitarian circumstances. It's not to sell it to big organizations as much as to demonstrate that is done and doable. We need to avoid to appear like we are, Columbus rediscovering the Americas. It's always been there. So we have to, I think what would be a very good effort is to invite many of the practitioners who have done it in their context to collaborate and provide a understandable, practical demonstration of how it was done, because most of us don't need more technical guidelines as much as to see how others resolve problems we're facing. Maybe we don't need the exact same solution, but we need to know that it's resolvable, what sort of compromises people went through to be able to do it well, and so on. So that I believe would be a big step, and that done, in a wider collaboration might influence policy and practitioners, because a lot of it is not about headquarters of organizations, and a lot of it is about practitioners actually taking that on board and making it happen. Would probably be a very good step in the right direction.
Thank you. Thank you so much. Well, I think we're out of time. I think we've maybe just begun a beginning here, but an important beginning of a beginning. So thank you so much, Dr. Nahla Ghafer, Dr. Taman Aludad, and Dr. Christian Tizimira for sharing your experiences, many of them quite painful. And thank you for the work that you're all doing. And I wish you strength and courage to keep doing it. Thanks to all who joined us. Again, a recording will be available at the website of the Harvard Medical School, Department of Global Health and Social Medicine.
Thank you very much.
All. Thank you.
Thank you. Thank you, Eric. Thank you, everyone.
Thanks so much. Bye.